My name is John Hanley. I'm a rheumatologist at Dalhousie University in Halifax, Nova Scotia, Canada. Welcome to the clinical treatment session, which will be chaired by myself and Dr. Orly Ross. The first lecture is an invited lecture, and it's my privilege to introduce Dr. Vicki Werth, who's Chief of the Division of Dermatology at Philadelphia Veterans Affairs Medical Center and also Professor of Dermatology and Medicine at the University of Pennsylvania. Dr. Werth is well known for her work and contributions in the area of research in cutaneous manifestations of lupus, and her research focus includes the effects of ultraviolet light on skin and skin cells. And she also has a clinical component to her research program and has developed the cutaneous lupus erythematosus disease area and severity index, both developed it and validated, which is the CLASI, now being used in many international trials. Her presentation this afternoon is Evidence for Treatment of Cutaneous Lupus, a Dermatologist's Approach. Dr. Werth.
Good afternoon, and it's my pleasure to be here and talking about treatment and evidence for treatment in cutaneous lupus. These are my conflicts. So cutaneous lupus is divided into chronic cutaneous lupus, which includes localized discoid lupus, generalized discoid lupus, hypertrophic, lupus profundus, and papulomucinous lupus. Other forms of cutaneous lupus include subacute cutaneous lupus and acute cutaneous lupus. And in terms of treatment, the point of showing you this slide is that there really are not very big differences between the approach to treatment for all of these different types of manifestations, as shown here with the various types of lupus. And that it would include also subacute cutaneous lupus, which you can see on the right lower picture here. Acute cutaneous lupus patients frequently meet SLE criteria, and the treatment would be directed again against if there is something seriously systemically involved with the patient that will contribute to deciding about treatment in the skin, and that would be true as well for the other forms of lupus. But if one is dealing only with the skin, we're going to discuss an overview about how to approach these patients. A skin biopsy for routine histology is often helpful. We do not usually or routinely do a lupus band test, which is non-lesional, non-sun exposed skin, but instead we do when there's a question about the diagnosis from routine pathology, we will do a direct immunofluorescence looking for immunoglobulins or complement in the skin. If the biopsy shows cutaneous lupus, then we proceed with the workup to exclude systemic disease. So once that's been done and one is dealing with skin disease, there are certain things that we now recommend. Some patients note that heat aggravates their skin, and we then would advocate they're not getting in situations where they're overheated. One thing that you really might want to mention to your patients is to avoid immunostimulatory herbs, such as those containing spirulina or green algae. There's good evidence that these can stimulate the immune system. Many of our patients are frustrated, and this is an area that I think we can caution our patients about as part of our treatment plan. In addition, avoiding certain drugs or stopping drugs that might be triggering lupus, and in particular subacute cutaneous lupus, is of importance. Drug-induced cutaneous lupus is most frequently seen in those with subacute cutaneous lupus. This is associated with an anti-SSA, SSB antibody perhaps 70% of the time and is typically not scarring. These patients are more elderly than other forms of cutaneous lupus, and these patients are frequently, because of their older age, on multiple medications. This is a list that gets ever longer of drugs that have been associated with subacute cutaneous lupus, and I want to point out thiazide diuretics, which were really the first drug class to be associated with SCLE, but Lamisil is one to really consider. Also, TNF inhibitors can also exacerbate SCLE, and the thought is that when you inhibit TNF, the interferon signature increases, and that has been associated with SCLE. In addition, statins have also been prominently a cause in some patients. So it's good to recognize this list and to evaluate patients when they present with SCLE to prevent them from or potentially stop these medications. And then also if a patient has SCLE, you may want to consider if there are alternatives to starting drugs that are on this list. There was a study done in Sweden of 234 patients with SCLE, and they looked at the general population in terms of matching in terms of prescribed drugs. And they found in these SCLE patients that 71% of patients had at least one filled prescription of a suspected drug. And this was the odds ratio for their study. But again, notice terbinafine, TNF inhibitors, and proton pump inhibitors are frequently used and infrequently can cause SCLE with an odds ratio of 2.9. But it's worth pointing out how many patients are on this, and if you have a patient with new onset SCLE who's on a proton pump inhibitor, you may want to consider alternatives. Also, antiepileptics, ACE inhibitors, and NSAIDs have been attributed. And at the end of the day, about more than a third of the patients that they examined with SCLE were attributed to drug exposure, and this was reversible once the drug was discontinued. So in terms of treatment, also sunscreens are very important to advocate for patients, and they must use really quite a bit of sunscreen, basically a shot glass of sunscreen each time it's applied, and they should apply 20 to 30 minutes prior to getting sun exposure. It's good to advocate for high SPF of 50 or greater, as well as a sunscreen containing UVA such as Mexeril SX. And in addition, if a chemical sunscreen is not tolerated, or if the patient prefers, physical blockers that contain titanium dioxide or zinc oxide are also effective. Also, hats, sun clothing, and sun avoidance should be suggested to patients. And if patients actually comply with these recommendations, it's really reasonable to check a vitamin D level, which is frequently low, and to make sure that they get adequate vitamin D levels. Now, this was a study that showed that sunscreen indeed is effective, and they tried to induce skin lesions of lupus by artificial light. And you can see that in the middle panel, sunscreen actually blocked induction of skin lesions by light related to lupus. So again, indicating that sunscreens can be relatively protective and should be used by our patients. In addition, I think it's important to especially involve patients who are male in the sense that they tend not to comply with sunscreen recommendations. And also, with patients with darker skin types are less likely to use sunscreens, and so they need special counseling as well in their use. This is an example of vitamin D levels, and you can see here that on the left, if all patients that were looked at, or all normals that were looked at, in the winter, they had low levels of vitamin D, and in the summer, their vitamin D levels actually increased. You can see right here it increased. But if you look at breaking down patients by whether they have allergies or if they're healthy, you can see that on the right-hand side, patients who had allergies and were healthy had higher vitamin D levels in the summer, but the lupus patients who must have indeed been quite compliant, and that would be these patients here, on the left-hand side of the right-hand graph, you can see that their vitamin D levels did not go up in the summertime. Now, other treatments include use of topical steroids, intralesional steroids, for instance, in the scalp or for individual lesions, and also topical nonsteroidal T-cell inhibitors such as tacrolimus and pimecrolimus. Topical steroids can be used, and the lowest potency required to achieve resolution for the shortest time is helpful. And on the face, where very often steroids can cause problems with atrophy or telangiectasias, a low mid-potency is usually recommended, such as hydrocortisone. Occasionally, a stronger steroid can be used, and then to taper down to hydrocortisone. Mid-potency steroids, such as triamcinolone or betamethasone, can be used on the trunk and extremities. And for palms and soles, or for transient use, clobetasol, which is a stronger steroid, can also be helpful. And intralesional Kenalog is usually given at a dose of 2.5 to 10 milligrams per ml, and usually very small amounts into lesions, and also to make sure that if they're injected deeply enough that you don't get atrophy, which can be a problem. Now, in terms of the calcineurin inhibitors, this is a study that was done that shows, in fact, relative to vehicle, that these patients did a bit better in terms of their clinical score in the skin. But by the 84 days, there was no difference between vehicle and the calcineurin inhibitor. And overall, there's not felt to be a difference in efficacy between the calcineurin inhibitors and topical steroids. They do cause transient burning, erythema, and irritation. They can be somewhat expensive, but for the face and for lesions where you might not want to use potent steroids, they don't cause atrophy. And so this is something that is helpful for thin skin, again, such as on the face. In terms of systemic therapy, there are almost no prospective double-blind randomized controlled trials, and thus the recommendations are based on expert opinion and retrospective case series. However, this is beginning to change, and many of the recommendations in the past and even now are based on algorithms that look at risk-benefit ratios, and we'll talk a little bit about this in terms of antimalarials and immunosuppressives with thalidomide. So we'll talk about antimalarials, and there was one randomized trial for a systemic drug for cutaneous lupus prior to the year 2000, and since that time there have been a few more studies. But in this study they compared acitretin to hydroxychloroquine, acitretin being a vitamin A derivative. And what this shows is that half the patients improved with hydroxychloroquine. So there's still lots of patients who don't get better. And this was, again, without really a validated disease severity measure. There was another retrospective study done and published relatively recently that was retrospectively showed that about 60% of patients with cutaneous lupus respond to hydroxychloroquine. And they looked at cigarette smoking and the CYP genotype, with the idea being that maybe cigarette smoking interferes with the effectiveness of hydroxychloroquine, and they did not find that association. They also found that those patients with disseminated disease and concomitant SLE had associated lack of response. Now, with the advent of a validated cutaneous measure for disease severity that has now been validated in terms of reliability, responsiveness, and also correlation with quality of life, using a quality of life measure in the skin, such as the Skindex, it's now been possible to prospectively follow patients who are being put on treatment. And in a single-center cohort of patients that were treated with antimalarials and prospectively assessed using the CLASI, it was found that about 55% of patients in the cohort responded to hydroxychloroquine. So now 3 studies saying about half of the patients respond, and they're pretty consistent. In this particular study that came from our institution, another 66% of hydroxychloroquine refractory patients responded to the addition of quinacrine or mepacrin, which is the other name for quinacrine, to hydroxychloroquine. So they were on quinacrine and hydroxychloroquine together. And this is just showing you data, showing you that their CLASI score was fairly similar to the beginning 0 times when they started the quinacrine in some of the patients who were followed ahead of time. And the responders, you can see, actually do uniformly seem to get better, which is not surprising, but a large percentage of these patients, again, 2/3, got better. And even those who were non-responders, judged on the basis of not enough change in CLASI, had a trend down. So if you have refractory patients not responding to hydroxychloroquine and you have access to quinacrine, that might be another possibility to add to the hydroxychloroquine. In addition, this study showed that some patients not responsive to the combination of hydroxychloroquine and quinacrine did respond to chloroquine. There has also been a study, a prospective cohort study related to smoking, that showed that it is worth giving the antimalarials a chance in smokers. And in fact, the people who only required antimalarials to control their disease seemed to do better if they were smokers than non-smokers. However, in the group that don't respond to hydroxychloroquine, those people don't tend to respond to anything, whether it be immunosuppressives or thalidomide, and they rapidly go into the refractory group. And these patients tend to have generalized discoid lupus. So the way that antimalarials are typically used is to start with hydroxychloroquine, less than 6.5 mg per kilo per day, give the patient 6 to 8 weeks to respond, and if they're not better, to add the quinacrine, 100 milligrams a day, wait another 6 to 8 weeks. If they're not better, stop hydroxychloroquine and consider starting chloroquine at a dose of less than 3.5 mg per kilo per day. Chloroquine has more eye toxicity, and thus it's not our first choice, and that's why hydroxychloroquine is used more frequently. There was a recent study that looked at antimalarials and showed that in 300 patients with either SCLE or chronic cutaneous lupus treated with hydroxychloroquine, those who responded tended to have a higher level of blood hydroxychloroquine concentration relative to those who had partial remission or were treatment failures. And complete remission was associated with higher blood hydroxychloroquine concentrations and the absence of discoid lupus, but not smoking. Discoid lupus, which is more frequently associated with cigarette smoking, appears to be more refractory to antimalarial therapy. And so those who have severe generalized discoid lupus are more likely to go on and be refractory. And also of interest, fully 10% of these patients had very low blood hydroxychloroquine concentrations and were considered to be non-compliant. So in terms of immunosuppressives, what's the evidence that if your patient has failed antimalarials, that these might be helpful? And up until recently, we had some case series and case reports suggesting that azathioprine, methotrexate, and mycophenolate could be beneficial. There was this paper that was looked at 10 patients with subacute cutaneous lupus. On the left, a patient prior to mycophenolate, and on the right, after. This is their arm, again, before and after. And here you can see CLASI scores decreasing in many of these patients, but not all. And this is before treatment and after treatment. And many of these patients did respond in this open-label trial of mycophenolate. Another study was an open-label prospective study of just 13 patients who didn't respond or didn't tolerate antimalarials, and half of these patients responded when treated with immunosuppressives. And this included, they noted, and this is again from our institution, that methotrexate and mycophenolate was more effective than azathioprine, but with these small numbers in an uncontrolled trial, one could not conclude very much, except that it can help some patients. However, of interest, when we looked at the quality of life in patients before and after treatment, those who were responders based on a change in CLASI score of 4 had actually improvement demonstrated by a decrease in the subcomponents of their quality of life score. This is before treatment and after treatment. And those who were not responders, what you can see is that there's no change in their quality of life. So in fact, the response is helpful in that the patients also feel that they've gotten some improvement when they in fact have been shown in terms of the CLASI-2 improve. So let's talk about thalidomide and derivatives. So there was a study that was published from Spain with 60 patients greater than or equal to 18 years of age, and effectiveness is up to 80 to 90% of patients, with improvements starting in 2 weeks and full effects in 4 to 8 weeks. The highest response was seen in SCLE and DLE, over 90% of patients, and the lowest was in lupus profundus, which is quite rare, 50% of patients. And there was no difference in response in localized versus generalized discoid lupus with thalidomide. There was a high rate of relapse, especially in DLE, in 4 to 8 months after stopping treatment, with a relapse rate that was somewhat lower in SCLE and higher, 84%, in discoid lupus. And in fact, some of these SCLE patients never really relapsed after stopping thalidomide, and so there was a question if early treatment might actually be somewhat remissive. These patients who relapsed respond to retreatment. 16% required maintenance, but side effects include drowsiness, paresthesias. We monitor patients with nerve conduction tests every 6 months, and very frequently these patients do get peripheral neuropathy. Also reversible amenorrhea, stroke, and increased plasma viscosity, and teratogenicity is a certain concern, and patients are monitored very carefully to prevent pregnancy. So here's a patient before thalidomide and after, and this is a pretty typical case that can be seen. So again, to emphasize, the response can be rapid with a full clinical response in 2 to 3 months, and many patients that are refractory to antimalarials do respond to thalidomide, and sometimes a lower maintenance dose, as much as 20 or 50 milligrams, 25 to 50 milligrams a day, or even once a week, can be helpful. Again, they can relapse, but they respond when they're started again. But it doesn't have a huge effect in terms of systemic lupus symptoms. It's really predominantly effective in the skin. And again, to emphasize the hypercoagulable state, and to be these patients, we typically will continue on Plaquenil or low-dose aspirin to prevent this from occurring. So what do you do if you have a refractory patient defined by not responding to immunosuppressives and also the antimalarials or thalidomide? And that's true in probably 10% of our population. And we find the patients who are refractory tend to have generalized discoid lupus or hypertrophic discoid lupus relative to those who have localized DLE where the response is better, or SCLE. But in those who have refractory disease, they do tend to be smokers, and you can see here the refractory patients, over 70% were smokers, relative to the non-refractory patients where they have a much lower amount of smoking. So there are some new studies coming along, nothing even close to any kind of approval, but just observations that have been made in some open-label trials. There are thalidomide analogs that are up to 50,000 times more active than thalidomide, potentially less neurotoxic, and they do have complex mechanisms that need to be studied in the context of any studies. So this was a patient, we did an open label study with 5 patients, and this is one patient here prior to treatment, and after 6 weeks, she was obviously much better with decreased erythema, decreased scale in her lesions. And this was a patient who had failed antimalarials, she failed thalidomide, immunosuppressive. So this was a dramatic improvement from her perspective. And you can see here that the skin also improved dramatically between week 0 and week 6. And this is showing that patient that as she improved, her dose was back down to 5 milligrams every other day of lenalidomide. And you can see her disease activity worsened. And it stayed about increased until her dose was again increased to 5 milligrams every day, and then she came down and did quite well. So I think that, again, for this patient, she did quite well. This was, again, open label, refractory CLE by definition for admission to the study. And 4 out of the 5 patients improved with a more than 4-point increase or improvement in the CLASI. 1 out of 5 did not respond, and 1 out of 4 who had skin improvement had new onset proteinuria and arthralgias, and clearly demonstrates a need for very systematic study to determine what the incidence is of systemic flares and so on associated with use of lenalidomide. So this is the CLASI activity scores in these patients. There were 5 of them, and 1 of them stopped early because not responding, and another because of the increased proteinuria. And so 3 of these patients continued and had a fairly decent response. The peripheral blood was examined by flow cytometry and did show that the T regulatory cells did increase, which one could think might be part of the mechanism for improvement. The peripheral blood also showed, though, some activation of T cells, and the one patient with new onset proteinuria had activated plasmacytoid dendritic cells. So one does have to, again, I think, advocate for doing very systematic studies before recommending routine use of lenalidomide. However, this patient, this is a study from Spain, Dr. Cortez Hernandez and her team, looking at 15 patients, 86% with complete response, and again showing a decrease in CLASI score that really demonstrates a very rapid and sustained improvement in, again, these 15 patients, 86% of them in complete response. So the last thing is that steroids, retinoids, belimumab, dapsone, and rituximab are kind of where you end up if you've failed all these other treatments. And systemic steroids are used minimally for the skin, except while hopefully waiting for the onset of action of other therapy. We don't routinely use this for skin-predominant disease. And then retinoids work but have many side effects and probably are not suitable for long-term therapy. There was a trial, as you know, of a betastep for systemic lupus, and it modulates T-cell activation and interactions between activated T-cells and B-cells. And there were quite a number of patients admitted to this randomized placebo-controlled trial where, unfortunately, primary and secondary endpoints were not met. And if you look at the skin results, there was no improvement based on a pre-specified flare endpoint. Belimumab stimulates, as you know, stimulates B lymphocytes to develop into mature B cells. It's been studied, as you know, in a number of large SLE trials, specifically 2 trials, where belimumab plus standard of care versus placebo plus standard of care, and the mean reduction in selenocytide was observed and led to a new approval. And of interest was this post-hoc analysis showing that, in fact, in a dose-response kind of way, that there seemed to be an improvement in the rash in patients relative to baseline. And so there's hope, and that potentially further study will demonstrate that the skin may benefit from treatment with betalutimab. Now, I do want to mention bullous lupus, where there are inflammatory cells that are neutrophilic, and that in patients who are not ill, they may benefit from use of dapsone, which blocks neutrophil migration and is effective for neutrophilic blistering conditions. And this may be a safer alternative than systemic steroids for patients who have mild bullous lupus and don't have severe systemic disease. There have been a number of reports of rituximab helping patients with refractory bullous lupus. And it would make sense because this is clearly an autoantibody-driven process with an antibody in general against type 7 collagen. So if you have a very refractory patient, one really might want to consider use of rituximab here. So I did want to mention that there is actually a randomized placebo-controlled trial ongoing in Japan by Sanofi to look at effectiveness of hydroxychloroquine in cutaneous lupus and SLE. And you might ask, why is this study ongoing? And it's because hydroxychloroquine is not available in Japan, and it will be a huge advance, and also to our knowledge base, to have such a placebo-controlled trial. So in summary, we have better sunscreens, and our patients need to be instructed to use them. We have topicals that have some fewer side effects in terms of particularly on the face. Better understanding of triggering medications. There's improved understanding of the response to antimalarials, and also on therapeutic need, that we do have patients who are refractory to current therapies. We have newer therapies to evaluate. There's a possible role for betalutimab in cutaneous lupus. There's early data on lenalidomide that is encouraging. Rituximab can be used for bullous lupus, although not approved for this. And we don't know in terms of some of these other skin presentations, but again, something to really strongly think about. And also very exciting, there are many potential treatments in the pipeline. Thank you very much.
Thank you, Dr. Werth, for your superb presentation. We have time for some questions or comments. Could you use the microphone, please, and identify yourself? Maybe while people are making their way to the microphone, if I could just ask you, with regards to your experience adding quinacrine or mepicrine to one of the more standard antimalarials, if you get a good response, can you maintain it by just continuing the quinacrine, which may be more attractive given that it's not said to have ocular toxicity?
So the question, so usually we find that quinacrine seems to work best in combination with hydroxychloroquine, and I don't think there's much experience with stopping hydroxychloroquine. I think it's also worth mentioning that eye toxicity is really quite rare in these patients, and in general the new recommendations are to monitor patients for eye toxicity at time 0, and then potentially have no renal problems or other risk factors for eye problems, maybe not even for 5 years after onset of use. And so I think the important thing is to stay within dosing recommendations, but we have really no additional data to recommend use of quinacrine alone.
Microphone. My name is Doug Smith from Ottawa. I loved your talk. Could you comment, when all else fails, on the use of camouflaging agents?
Right. So camouflage is quite helpful for patients who have scarring or even active disease. And usually we use CoverMark or DermaBlend, which can be fixed with a powder. It can be matched to the patient's skin color. And patients often benefit from use of this. And thank you for asking that question.
Time for one more question.
Thank you, Hübscher, Buenos Aires. I think you haven't mentioned lupus tumidus. What is your concept about lupus tumidus? And question number 2, what is your current policy on retinal OCT controls in patients that are expected to take hydroxychloroquine for decades?
Okay, so a couple of things. So your question was about eye monitoring for hydroxychloroquine?
That was the second question.
Okay.
The first question, lupus tumidus.
Tumid lupus is really different. There's characterized by a lack of vacuolar alteration. The histology is completely different. And you get glycosaminoglycans and inflammation around vessels and hair follicles. Clinically, it's very photosensitive and tends to be usually very responsive to hydroxychloroquine, but it seems to be in a spectrum of the disease that's somewhat distinct from discoid lupus, SCLE, and acute LE because you lack the interface dermatitis with the inflammation at the dermal epidermal junction. In terms of routine monitoring, right now the eye monitoring for hydroxychloroquine, as I mentioned from the American Ophthalmology Group, has been to do baseline monitoring and then after 5 years. And again, I think it's a new recommendation. I think most people are monitoring somewhat more frequently than every 5 years, but not as often as every 6 months at the beginning. And then their recommendation is after 5 years to monitor yearly. After that, I think the guidelines, all of the antimalarials were lumped together, and I think the experience is that chloroquine is more, it causes more eye problems, and therefore patients who are on chloroquine would likely require more monitoring than what is suggested with the hydroxychloroquine.
I think in the interest of time, we will have to move on. Thank you very much, Dr. Werth.